بسم الله الرحمن الرحيم. هنتكلم النهارده على head and neck cancer as a risk factors and presentation. What is meant by head and neck cancer? Head and neck cancer is a tumor arising from the epithelial lining of the upper aerodigestive tract. All the epithelial lining of the upper aerodigestive tract. Mostly it is squamous cell carcinoma. The primary site of head and neck cancer may be in the oral cavity, in the pharynx, larynx, or nasal cavity and the paranasal sinuses. By oral cavity, I mean the lip, floor of the mouth, oral tongue, buccal mucosa, alveolar ridge or alveolar margin, the hard palate, and the retromolar area or retromolar trigone. Pharynx by its three parts, nasopharynx, oropharynx, and the laryngopharynx or hypopharynx. Larynx by the supraglottic area, glottic area, and the subglottic area. By the nasal cavity and the paranasal sinuses, I mean the nasal cavity, maxillary sinus, ethmoidal sinus, frontal sinuses, and the sphenoid. The oral cavity and the paranasal sinuses. What is the epidemiology? Head and neck cancer represent about 3% of all new cases of cancer in the United States. In spite of it represent only 3%, 2% of cancer deaths. It represents 2% of cancer deaths. Male to female ratio is about 2.5 to 1, but it is more higher, may reach 7 to 1 in cancer larynx, which is more common in the male. About 75% of head and neck cancer related to cigarette smoking and alcohol. If we use both tobacco and alcohol, the risk increase up to 15 times. Cancer nasopharynx and the paranasal sinuses are not related to the tobacco and alcohol. This is the paradox. This is the only cancers or the only site which is not related to alcohol and tobacco, but related to certain industrial material and occupational disease. The survival rate of the head and neck cancer, 1 year survival after diagnosis about 84%. The 5-year survival about 61%, 10-year survival about 50%. This survival related to the stage of the disease. If we diagnose the case with local disease, not spread to the regional lymph node or to the distant site, the 5-year survival may reach to 82%. But if there is regional involvement, the 5-year survival decreased to 56%. If there is distant metastasis, it is very low to 34%. As we show in this table, cancer represents the second cause of death after the heart disease. The risk factors for head and neck malignancy including number 1, tobacco products, either smoking, cigar, pipe, chewing tobacco, or snuff. Ethanol products, some chemical as asbestos, chromium, nickel, arsenic, and formaldehyde. Other factors as ionizing radiation, Plummer-Vinson syndrome, Epstein-Barr virus, human papilloma virus, leukoplakia. The male gender is by itself is a risk factor. It increases the risk 2 to 3 times. Age also, more than 40 years. Petal nuff chewing also is a risk factors. Tobacco and heavy alcohol smoker are the most common risk factor for head and neck malignancy. This including cigarette, cigar, and chewing tobacco. Cigarette smoker have a lifetime increased risk for head and neck malignancy 5 to 25%, 25 times over the general population. Even ex-smoker even after the individual stop smoking. Head and neck cancer begin to approach more than the general population begin to approach the general population 20 years after stop smoking. The risk extends till 20 years after stop of smoking. Other possible occupational risk factors as wooding industry, woodworking, laser tanning, nickel refining, texture industry, radium dial painting. Smoker tobacco and other oral chewing materials are carcinogen, are associated with development of cancer in the oral cavity. Plummer-Wilson syndrome, high risk for post-coracoid carcinoma and hypopharyngeal malignancy. Maxillary sinuses are associated with certain occupational exposure as nickel, radium, and mustard gas, chromium, and byproducts of laser tanning and woodworking. Human papilloma virus associated with oral malignancy. The most common type is human papilloma virus type B53 and BRP protein in causing the cancer. E6 and E7 are human papilloma virus protein causing inactivation of the tumor suppressor gene B53 and BRP, resulting in loss of cell regulation, leading to cell proliferation and chromosomal instability. Also, human papilloma virus associated with oropharyngeal cancer. This occurs in younger age with recurrent oral human papilloma virus infection or high risk sexual behavior as first sexual experience at younger age or increased number of vaginal or oral sex partner. In some cases, we find axillary or cervical lymph node affection without known primary source. This is caused metastasis of unknown origin. Lymph node in the neck with malignant pathology without any obvious primary mucosal origin. Head and neck cancer with unknown primary are generally squamous cell carcinoma. And if we take biopsy from this lymph node, the pathologist comes a report squamous cell carcinoma. This represents about 2 to 3% of head and neck malignancy. Lymph node of the neck divided into 7 levels. The first level including the submental and the submandibular lymph node, and this is divided into sublevel A and B. A including the submental lymph node, the submental triangle. B is the submandibular triangle. The level 2, 3, and 4 all represent jugular chain, upper jugular, middle jugular, and lower jugular. Level 2, which is the upper jugular, divided into A and B. A anterior to spinal accessory nerve, B posterior to the spinal accessory, then middle jugular and lower jugular. Level 5 present in the posterior triangle of the neck. Level 6 represents the central chain present in the center of the neck. Level 7 is the superior mediastinal lymph node. This is the figure represent the levels of the lymph. Not all ulcer present with symptoms at early stage. Not all cancer present with symptoms at the early stage. Transformation of normal mucosa to invasive squamous cell carcinoma doesn't occur all of a sudden, but the normal epithelium undergo hyperplasia, then dysplasia, then change to carcinoma in situ, then invasive carcinoma, then metastasis. All this under chromosomal and genetic control. What is the clinical presentation? Patient with head and neck malignancy may coming with distant metastasis in less than 10%. The first symptoms may be distant metastasis in about 10%, or may complaining of painless lump in the neck, most often discovered by the patient, usually at least 2 to 3 centimeter in diameter, not responding to antibiotic. Benign mass are often solitary and painless. Local regional signs and symptoms, as is the hypopharyngeal or laryngeal carcinoma, patient may complaining of sore throat, hoarseness of voice, or dysphagia. Glottic laryngeal involvement detect earlier as a change of voice is obviously noted. When we're facing a case with suspect hidden malignancy, we must differentiate from the benign lesion, which may be developmental as thyroglossal cyst or branchial cyst or inclusion cyst, or inflammatory mass as lymphadenitis, or benign reactive hyperplasia or infected sebaceous cyst, or benign tumor as lipoma, fibroma, hemangioma, neurofibroma, parathyroid adenoma, or the malignant, all the benign lesion, this is the most common. Benign neck mass are most common, except in the supraclavicular lymph nodes. Malignant lesion, mostly metastatic carcinoma, maybe lymphoma or leukemia, carotid body tumor, primary major salivary gland tumor, parotid or submandibular or sublingual, thyroid malignancy or parathyroid, histiocytosis or carcinoid tumor. By physical examination, we must do complete examination of the head and the neck. Don't forget examine of the oral cavity and oropharynx with mirror or with fiber optic endoscopy. Pay attention to cervical lymph node. If we find the lymph node soft and rubbery, this suggests lymphoma or leukemia. If it is hard and fixed mass, suggests carcinoma. In some cases, we may need examination under anesthesia for larynx and pharyngeal tumor. What investigation can be done? At first, neck CT, followed by MRI if inconclusive. If the CT is inconclusive, we need MRI. PET scan if there is still no imaging data for the primary lesion. Positron emission tomography may be ordered. X-ray chest to rule out the lung metastasis or secondary lung primary. CT chest shows the incidence of spread below the clavicle at time of presentation is less than 10%, except in the nasopharyngeal carcinoma. So CT chest is not indicated unless the patient has bulky neck disease. I mean, the incidence of spread below the clavicle at time of presentation is low, less than 10%, except in the nasopharyngeal carcinoma. So CT chest not indicated unless the patient has bulky neck disease. PET scan with CT needed only if the CT is equivocal or primary site is unknown. And triple endoscopy for upper digestive tract, for the upper airway, and for the nasal sinuses. Then we need biopsy, fine needle biopsy from the primary site or from the lymph node, incisional or excisional biopsy before definitive treatment have increased the rate of neck recurrence, distant metastasis, and wound necrosis comparing to the patient without biopsy. So, needle biopsy be referred to excisional biopsy to avoid theoretical risk of seedling along the track. needle biopsy be referred to excisional biopsy. So, I means uh, uh, there is theoretical risk of seedling along the track in case of needle biopsy. So it is better to do excision biopsy. Then laryngoscopy, direct laryngoscope and the biopsy of the nasopharynx, tonsils, base of the tongue, piriform sinus, as well as suspicious area seen on image by CT or MRI. Screening tonsillectomy. If the primary site has not been discovered by all these measures, an ipsilateral screening tonsillectomy may be performed. In these cases, there is great benefit in patients with subdiagnostic, with subdigastric or submandibular or mid-jugular lymph node involvement. In a study of 87% in 87 patients with unknown primary site, 26% were discovered to have tonsillar primary carcinoma after tonsillectomy. This CT scan of malignant lymph node what is the relation of the lymph node location of the lymph node to the most likely disease? If we find that the upper neck node is enlarged, so the most likely is head and neck malignancy. If we find the enlarged lymph node is the subdigastric or jugulo-digastric lymph node, this may be virtually any head and neck primary or non-Hodgkin lymphoma. If we find the enlarged lymph node in the submandibular, the primary may be in the oral cavity, lip, nasal vestibule, or salivary gland primary site. In the submental lymph node, the primary site is uncommon. If parotid lymph nodes are enlarged, the primary is mostly in the skin cancer or primary parotid tumor. If we find the enlarged lymph node in the mid-neck, the likely primary may be in the larynx, hypopharynx, and less commonly esophagus or disease below the clavicle or lymphoma. If we find the enlarged lymph node in the lower neck or in the supraclavicular area, most often metastasis from chest or abdomen, possibly esophagus or lymphoma. Primary head and neck malignancy is uncommon at this level. The oral cavity usually is spread to the level 1. Laryngeal carcinoma to the level 2 and 3 lymph node. Disease in the level 4 or 5, suspect thyroid or primary below the neck. Staging of the head and neck malignancy according to the TNM staging system 3000. T site, T represents the primary tumor, N represents the regional lymph node, and M represents the distant metastasis. From T1 to T3, there is also only increase in the size of the tumor. T4, invasion of the muscle, cartilage, or bone. We can divide it into A and B. A if it is surgically resectable, B if it is locally unresectable disease. The lymph node can be divided into 3 levels. N1, ipsilateral single lymph node, less than 3 centimeter, less than or equal 3 centimeter. N2, if ipsilateral single lymph node, more than 3 centimeter or from 3 to 6 centimeter. B, ipsilateral but multiple, also from 3 to 6 centimeter. 3, if it is bilateral or contralateral. N3, if the lymph node more than 6 centimeter. By other means, N1 3 or less than 3, N2 3 to 6, N3 more than 6. This is for all head-and-neck malignancy except the nasopharynx and the thyroid. For the nasopharynx, N1 unilateral node less than or equal to 6 centimeter above the supraclavicular fossa. N2 if bilateral lymph node less than or equal 6 centimeter above supraclavicular fossa. N3 divided into A and B, A more than 6 centimeter, B in the supraclavicular fossa, more than 6 centimeter also. In the thyroid, N1A if there is affection of level 6, N1B if there is other region. So T1 tumor less than or equal to 2 centimeter, T2 to 4, T3 more than 4 centimeter, divided into 4A and B as previously mentioned. 4A if there is a resectable disease, B if unresectable sites. And this is the lymph node. N1 less than 3 centimeter or equal 3, N2 3 to 6, N4, N3 more than 6 centimeter. M0 no distant metastasis, and M1 there is distant metastasis. Then we put the stage of the disease. Stage 0 if it is carcinoma in situ without affection of the lymph node or distant metastasis. Stage 1 T1 N0 M0, T2, and this is the other staging. Recently in 2017 put another the TNM staging differ only in the T stage. He added the depth of invasion. According T1 tumor size less than 2 centimeter and the depth of invasion less than 5 millimeter. T2 tumor size less than 2 centimeter and the depth of invasion from 5 to 10 millimeter. T3 depth of invasion more than 10 millimeter. T4A extra or extrinsic tongue muscles infiltration. What is the management? Is for stage 1, 2,
new classification,
and local stage 3. The treatment is single modality, either surgery or radiotherapy. And we achieve cure rate from 52 to 100% depending on the primary site. But higher stage, stage 3 and stage 4, we need multimodality. If resectable, surgery is the first choice, followed by radiotherapy plus or minus chemotherapy based on the pathology. If unresectable, chemoradiotherapy, and in this cases the cure rate is about 10%, and often with disfigurement, functional disability. If there is recurrent, the salvage surgery, if possible surgery, it is better. If no, if the patient not received radiotherapy before, so radiation indicated with chemotherapy. In these cases, the survival is very poor, about months, 5 to 9 months. The principle of surgery is complete removal of the tumor with negative margin with block dissection of the lymph node. Radiotherapy may be primary treatment or adjuvant treatment. Primary treatment usually as single modality for early stage of the disease only, or to the lymph node, or adjuvant 4 to 6 weeks after surgery. Chemotherapy as a single modality is not curative for head and neck malignancy, so it's given as adjuvant treatment. The new one is a target therapy. may be given in combined with radiotherapy or with chemotherapy. Nasopharyngeal carcinoma will be discussed in another lectures. So, when possible, surgery is the first choice, unless we are trying to save the organ. We then try chemotherapy or radiotherapy. Current therapy for oral cavity, squamous cell, and oropharynx and squamous cell carcinoma, including isolated or various combination of surgery, radiotherapy, chemotherapy, and immunotherapy. All oral cavity squamous cell carcinoma treated with surgery unless metastatic or unresectable, or if there is contraindication to surgery. So stage 1 or 2 oropharyngeal malignancy, surgical treatment. Stage 3 and 4, combined treatment. Prognosis, the best indication for prognosis is the end stage. If there is, and the presence of extracapsular invasion to the lymph node. Prognosis is similar between the patient with known versus unknown primary site of the same nodal stage. Thank you.